స్టార్ట్ అయింది కానీ మరి నాకు ఇది కావాలి. రైట్, నాకు కనిపిస్తుంది ఇక్కడ. ఓకే, గుడ్ మార్నింగ్ dear students. Today we'll discuss about the complications, intracranial complications of otitis media. Now, basically, the complications of otitis media are defined as the disease extending from the mucoperiosteal layer of the middle ear cleft, middle ear cleft, and into the surrounding structures, neighboring structures, like the erosion of the bone, the facial nerve, the dural venous sinuses, meninges, the brain tissue, and extratemporal soft tissues. So basically, we'll try to come back to the basics and try to see the middle ear cleft consists of the eustachian tube, the middle ear cavity, the editus, and the antrum, mastoid antrum, along with the various groups of air cells. And these air cells are usually named after the important structures with which they are in relation to. For example, there are a group of cells which are behind the facial nerve. They are called perifacial cells. Around the labyrinth, they are called perilabyrinthine. Around the sigmoid sinus plate, they are called perisinus. So the various groups of air cells are named after the structures which are in relation to that important structure. Now, the second thing that we need to understand is there are three variants of the mastoid. The mastoids are either cellular and sclerotic, or via media, which are called the diploic. So we have seen in the acute otitis media the infection from the nasopharynx, and either focus of infection is in the adenoids or in the sinuses, travels via the eustachian tube, comes into the middle ear cavity, and there it starts proliferating. And we have seen the various stages of acute otitis media, wherein the stage of tubal occlusion, the stage of exudation, stage of suppuration, and then which slowly progresses to the stage of resolution or the stage of complication, depending on the various factors, the patient factors and the treatment factors, treatment whatever is given when they approach the doctor. And there are various other factors which influence the infection spread from one area to the other. Now, we have seen the infection right now in the acute otitis media. It is through the passages, through the eustachian tube, through the middle ear cavity, the editus, which is the connection between the editus to the antrum, mastoid antrum, and antrum in turn is connected to the various groups of mastoid air cells. So, and we have also seen that the acute otitis media, basically the pathophysiology is the obstruction after the infection goes into the middle ear cavity, the obstruction of the eustachian tube, and there is multiplication or proliferation of the pus infected material in the middle ear cavity, which is under pressure. And if we try to recapitulate the anatomy of the middle ear cavity, it is like a matchbox with 6 sides. The roof is formed by the tegmen tympani, the floor by the jugular bulb. The anterior wall is otherwise called the carotid wall, which contains the internal carotid artery. Then the posterior wall is called the mastoid wall. Okay? And medially, you have got this in the medial wall of the middle ear cavity. You have the promontory, which is the prominent part formed by the basal turn of the cochlea. Then you have the oval window, which is covered by the footplate of the stapes. Then you have the round window just below that, the round window which is covered by secondary tympanic membrane. And we know that the just above the oval window, the horizontal part of the facial nerve runs, and then as it comes backwards, turns down in the form of a second genu to become the vertical mastoid component, and this mastoid part is exited, or it comes out through the stylomastoid foramina and comes into the soft tissues of the neck. And just above the oval window, as we said, is the facial nerve, and just above that, in the adytus, that is the passage between the middle ear cavity and the mastoid antrum, you have another small elevation which is formed by the horizontal semicircular canal. Okay? Now these are the structures which are present in the medial wall of the middle ear cavity. Whereas the lateral wall of the middle ear cavity, you have the tympanic membrane and the middle ear cavity, which is in line with the tympanic membrane, is called the mesotympanum, and above that is the epitympanum, and below is the hypotympanum. Now if you see the relations of this middle ear cavity, there are certain weak areas through which the infection can spread from the middle ear cleft, either from the middle ear cavity or the mastoid, into the intracranium, and produce damage to the cranial structures which are present. Now let us try to see what are the intracranial structures which are in close relation to the middle ear cavity. If you see the tegmen tympanum are in relation to the, once that bone is eroded, it is you enter into the middle cranial fossa. Now before that, I would like to show you the same line diagram. Eustachian tube, middle ear cleft, showing the middle ear cleft, eustachian tube, middle ear cavity, adytus, antrum, and the various groups of hair cells. Then we go to the another picture here. Now this is the temporal bone. The temporal bone is the one which is in which is the external ear, bony part of the external ear, the middle ear cavity, and also the inner ear, which consists of the cochlea and the labyrinthine apparatus. So these are the and the various parts are being described: the squamous part, the tympanic part, the mastoid part, and the petrous part of the temporal bone. Now, the petrous part of the temporal bone, which is the inside one, is the one which is in relation to the middle cranial fossa and also the posterior cranial fossa. Now, the structures which are in relation to the mastoid antrum and the mastoid air cells posterior-medially is the sigmoid sinus plate, and the above is the temporal bone, which separates this middle cavity, the antrum and the mastoid antrum, from the middle cranial fossa, tegmen antri, and posteriorly, I'll show you a small diagram which is wherein you would say posteriorly, this is the sigmoid sinus, and that is the superior petrosal sinus, and you have the labyrinth there. So it forms a triangle which is called the Trotman's triangle. Now, if the infection spreads through this area, it goes into the posterior cranial fossa. Now, usually these are if you go into the intracranium, you have these sinuses, venous sinuses, which are present in the dura mater. Split of the dura mater takes place, and you have these dural sinuses, which are the venous channels which drain the intracranium. And these are major part of the superior sagittal sinus, the inferior sagittal sinus, the transverse sinus, which becomes the transverse sinus, and this transverse sinus in turn goes to the sigmoid sinus, and this sigmoid sinus goes through the tubular foramina, and then comes in relation to the inferior part of the middle ear cavity, where it forms the jugular bulb, and then from there it descends down as the internal jugular vein, which joins the subclavian vein from the same side and becomes the innominate, and which together form the superior vena cava, and joins from the opposite side and enters the right atrium and right ventricle. From there, the blood is pumped into the lungs. So this is how the venous system, drainage system works in the intracranium. So these are the dural sinuses which are present in between So these are important for us to study, because the infection, because of the close proximity of these the infections of the middle ear cavity and the mastoid, are likely to extend into these areas, into these sinuses, and from there they propagate themselves either retrograde or antegrade to cause the various clinical signs and symptoms. We will come to that later. That is as far as the sinuses are concerned. Okay. Then we see that in the normal person, usually the infection from the middle ear cavity doesn't easily go into the intracranium, because there are some layers, there are some bones, the bony part, and if you take a section of the starting from the skin to the intracranial area, you've got the skin, which is the outermost part. And then, of course, the aponeurosis, that is in the temporal region. You have the temporal fascia and temporalis muscle, and then deep to that is the squamous part of the temporal bone, which is covered by the periosteum. And after the periosteum, as you see in the diagram, you have the bone. The bone in the intracranial region is covered inside, lined inside by the dura mater, which is the outer layer of the meninges. And later is the arachnoid, and then there is a space in between where the CSF is present, and the inner one is the pia mater. So these are the various layers if you see from outside. This is normal structure, but sometimes what happens is there are some weak spots, weak areas in the middle ear cavity, maybe congenital weakness of the tegmen tympani, congenital dehiscence of the facial nerve canal, congenital deficiency of the jugular plate. Okay? So these are the ones which are present congenitally, and in addition to these, there are some weak areas or areas where through which, if the pressure is built up, the infection can push itself into the intracranial region. These are nothing but the suture lines that you see in the temporal bone. The suture lines, these are the suture lines. Okay? Suture lines which are seen and sometimes they are a little more patent, and so the infection can travel from this when there is a pressure built up into these regions. And apart from that, you have these in the middle ear cavity. We have seen that it contains the oval window and round window, through which the infection, if under pressure, can lead to inside into the labyrinth and the cochlea. From there, it can spread along the internal artery meatus and into the posterior cranial fossa, into the meninges. Okay? So that is the pathway of low resistance. So the infection can travel to that. Sometimes there may be a fracture in the temporal bone, and this has not healed, and so the infection is once again can travel from these fracture lines into the intracranium. And the other trauma, that is the iatrogenic trauma, wherein you can see that the various surgical procedures that are attempted in order to see that the mastoidectomy. In the process, sometimes the dura is exposed, and sometimes the facial canal is partly exposed. Okay? And sometimes when you do a stapedectomy, you are making a artificial communication between the middle ear cavity and the inner ear. Okay? So these are the various other predisposing factors which in turn help the infection. These are the weak areas from where the infection can travel into the intracranium. Apart from this, we have these two conditions which we have studied: the acute otitis media and the acute otitis media, which is usually found in the cellular kind of mastoids, particularly in children. And there is infection which comes via the eustachian tube into the middle ear cavity. Eustachian tube gets blocked. The infection travels. Infection increases and puts pressure on the tympanic membrane. And sometimes, before the tympanic membrane yields, because that is the only area which can rupture. Before that, the pressure can push the infection from the editus, which is a normal passage from the editus into the mastoid antrum and into the various air cells, where initially the buccoperiosteum becomes thickened, inflamed. Then there is inflammation, and inflammation occurs wherein the mastoid, the editus, is blocked. Once the editus is blocked, the infection is not able to drain out, and when the infection multiplies, there is damage by the pressure and by the hyperemic osteitis that is produced. And so all these cellular cells of the mastoid air cells, the partitions are totally destroyed and becomes a single coalescent mastoiditis. This is what we have seen in the previous classes. So the coalescent mastoiditis, wherein the hyperemic osteitis is the major cause for dissolving of these bone, can also affect the tegmen anteri, tegmen tympani, or through the Trotman's triangle into the posterior canal fossa, and also the sigmoid sinus plate, and may be eroded and can lead to a kind of a extradural abscess in the perisinus area. Okay? And that is one way of spread of infection because of the infection, acute infection. In chronic suppurative otitis media, we have seen the two varieties. One is the safe or tubertympanic. Second one is the atticoantral. In the atticoantral, we have seen that the infection is in the form of the epithelial pearls, the skin, which keep multiplying and keep on adding, and these in turn release certain enzymes which slowly dissolve the bone. So this is called the cholesteatoma, which is slowly spreading. It may spread in various directions. It may spread in various directions, and it can spread into the superiorly, and it can spread posteriorly, and along with that you have these the granulation tissue which is also there. So these result in the slowly bony absorption, osteoclastic activity, and the infection. There is a big area that is created into the intracranial region through which the infection spreads. Now, these are the various conditions that we have described, and there are other factors as we have earlier described for the acute otitis media. The factors influencing development of complications are the age factors. The child and the elderly people have low resistance. They're on the, and so they are prone for these kind of complications. Then second one is the poor socio-economic group, where there is overcrowding, poor health education, and poor personal hygiene, limited access to the health care. Okay? They are in villages, the doctors and hospitals are not available. And they are not also conscious, poor health education. And apart from that, the other factors are the virulence of the organism, and antibiotic sensitivity. They become resistant, and so the organisms which were responding at one time to the antibiotics, they don't respond anymore, and so they spread the infection. Then the other conditions where there is a immunocompromised condition, wherein the AIDS, the uncontrolled diabetes, patients who are on immunosuppressive drugs, who have undergone some kind of a transplantation, and people receiving anti-cancer therapy, the chemotherapy, where the blood cells, the platelets, the RBC, WBC, totally are decreased, and so there is no the immunologically they are compromised. So these are the various conditions, some anatomical conditions, congenital, traumatic, inflammatory, the acute otitis media and the cholesteatoma. Sometimes some kind of a neoplastic, new growths, which can also slowly erode the bone and can give rise to a pathway connecting the middle ear cavity or the antrum into the intracranial region. So these are some of the diagrams how the infection spreads into the intracranium. Now, second mode of spread of infection, apart from through the bone, either because of weak areas or a destruction of the bone or deficiency in the bone. The second mode of spread is the vascular mode. Now, vascularity is the vascular in the sense you have the arteries and the veins. The veins are the ones which have a thin wall, and so during the infective state, the blood vessels, the thin veins get ruptured, and so these become passage of this infection from the middle ear cavity, and in the veins there is a negative pressure. So actually this infection is pulled into the venous areas, and these veins are in turn connected to the intracranial sinuses which we have described, the venous sinuses. Now we'll see these are the various factors which influence the spread of infection from the bone via the bone through some weak areas like the oval window and the round window, the suture lines, and some of the surgical or traumatic conditions, and the venous thromboembolic phenomena. The infection spreads into the intracranium, and this is how it is described. And the bone doesn't have the blood vessels, and the bone has got the Haversian system. From the Haversian system, the dural veins, and dural veins in turn are connected to the dural sinuses. So that's how the infection travels. And these are the other modes which I have already described. The complications of these infections, as we see. This is how the structure of starting from the skin to the intracranium. Would like to repeat again: the skin, the aponeurosis, the periosteum, and the bone, the dura mater, the arachnoid mater, and the pia mater. And then deeper to the pia mater is the brain tissue. So slowly the infection, either by destroying the bone or through thromboembolic phenomena, the infection spreads into the intracranium. Now we'll slowly see how the infection, to start with, by osteitis and the destruction of the bone, the infection has gone into destroy the bone and lies in between the bone and the dura mater. This is called the extradural abscess. Now this extradural abscess, almost most of the time, is because of the bony destruction. Okay, and so we have seen the various ways in which the bone gets destroyed, and as the infection enlarges, the dura is slowly separated from the bone. Now, as we have seen, this is usually in the middle cranial fossa or the posterior cranial fossa, or sometimes there may be infection infection from this extradural space, because there is already the erosion of the bone, it can spread into the subperiosteal region, particularly in the frontal region, into the frontal region, and this is called a Pott's puffy tumor. So the bony destruction, the infection goes into the extradural space, that is the space between the bone and the dura mater. As the infection enlarges, there is a separation of this dura mater, and there is a pressure that is exerted on the intracranium. As you know, the cranium is a closed space wherein if there is increase of some space occupying, let it be a fluid or let it be the infected material, the purulent, or some kind of a tumor or a hematoma, whatever is the one, it puts pressure locally on the brain. And there are certain clinical signs and symptoms which are in relation to the raised intracranium, and these symptoms are usually the headache is one, and the vomitings, projectile vomitings. And when you look into the eye, when you do a retinal examination, you will see the papilledema. So there is raised intracranial tension produces these symptoms: the headache, the projectile vomiting, and when you see, you will see the papilledema occurring. So these are because of the infection and because of the pressure that is exerted by this the purulent material that has gone into the extradural space. So usually these people will have a continuous pulsatile drainage from the ear discharge, the pulsating ear discharge. And sometimes the pulsating ear discharge, there is more discharge, so it drains out the abscess or partially relieved, and the headache comes down. So the main clinical features are the persistent headache, fever because of the septicemia, and ear discharge. When the pulsatile discharge is more, the headache comes down because it is draining. And the treatment here is the antibiotics if it is not responding. A CT scan will tell us that there is a deficit in the bony part and the dura is elevated from the bone, and so once we make a diagnosis of extradural abscess, the treatment is by the drainage of the abscess. Okay? And at the same time, if there is a focus of infection that is usually detected during the surgical procedure, is to do the mastoidectomy wherever is or a modified radical or a radical, whatever is the surgical procedure that is required to eradicate the root cause of this infection. So that is as far as the extradural abscess is concerned. Then we go a little deeper into this. The extradural abscess, maybe a little variant, is the space between the sigmoid sinus. The sigmoid sinus. The lateral sinus is nothing but the horizontal, the transverse sinus. The transverse sinus becomes the sigmoid sinus. So the sigmoid sinus continues, or this way is the transverse sinus, and the sigmoid sinus is connected to the cavernous sinus, by the superior petrosal sinus. There are venous connections, and the transverse sinus in turn joins the other transverse sinus from the other side, and there actually the reverse. In the venous side, usually you trace from the periphery. So there is a superior sagittal sinus, as I have told you, the superior sagittal sinus, which drains into the straight sinus, and which is joined by the superior sagittal sinus, inferior sagittal sinus, and together they form the transverse sinus, and which becomes the sigmoid sinus. So the sinus plate, which is eroded, if it is eroded, and it lies into the just like the extradural abscess. The extradural abscess, the infection comes into the sigmoid sinus, and when the infection comes to the sigmoid sinus, there is a irritation that happens in the intimal layer of the sigmoid sinus, and this in turn produces the accumulation or the attracting the platelets, which forms a small thrombus. This thrombus slowly enlarges in size, occluding the jugular, the sinus, and into this sinus slowly, when there is infection from the extradural space, infection is continuing, and it forms a slow central abscess formation, which in turn is responsible for the various systemic manifestations, and also, as I told you, the systemic manifestations are in the form of fever and the malaise, whereas the sigmoid sinus, there is a small emissary vein which drains the mastoid area of the skin of the mastoid area, and because of this clot that is formed in the sigmoid sinus, this emissary vein is blocked, and so there is a retrograde pressure that occurs, and so there is edema of the posterior, the mastoid region, and it also produces a kind of a tenderness, and so this is called a Griesinger sign. Griesinger sign is the sign wherein there is a edema and tenderness over the mastoid region, wherein the emissary vein, which is draining that, is blocked because of the clot that is formed in the sigmoid sinus. And apart from that, because it is space occupying, it also produces the headache, signs of increased intracranial pressure, as I told you, the headache, the vomiting, and the papilledema. And the clot has got a tendency to spread antegrade or retrograde. Now, if it spreads into via the superior petrosal sinus, it can lead in, it can block the cavernous sinus. It can block the cavernous sinus, and if it slowly spreads towards the transverse sinus and goes to the torcula, that is the junction where the superior sagittal sinus joins the occipital sinus, and together they form the transverse sinus. So from there it spreads into the superior sagittal sinus. It spreads into the inferior and superior sagittal sinus, and so it produces the kind of a blockade in the venous system. And as I told you, the fever is usually manifested once there is infection, with each bout of fresh infected material being released in the form of emboli. The clinically they manifest in the fever, and this fever is usually referred as picket fence fever. Okay? Picket fence fever, there is a hike and comes down once the infection is spread, and there is another bout of fresh septicemia that is occurring, and once again the fever goes up. So that is the classical picture of a picket fence fever. And the persistent fever, if it is continuous, as I told you, the cavernous sinus into the transverse sinus to the superior and inferior sagittal sinuses. But if it spreads via the sigmoid sinus into the jugular foramina, via the jugular vein into the internal jugular vein, it produces the clot which is extending into the jugular vein, and you can feel a tender cord in the neck region when this jugular vein is the thrombus or extends into the jugular vein. And of course, when it goes into the cavernous sinus, you have this bilateral orbital involvement, chemosis, high fever, ophthalmoplegia, and retinal engorgement. That is as far as the disease pathogenesis is concerned. Then we come to the management. To the CT scan, there is a sign which is called the delta sign, as you see the pointer, and the angiography or venography that is done indicates that there is a blockage of the transverse sinus, the sigmoid sinus, and so there are certain tests which are done in order to establish. And these tests, one is called Tobeyer test, wherein you block the internal jugular vein on the same side, usually, and you connect a manometer, do a lumbar puncture and connect a manometer. The usual CSF pressure is to the tune of 70 to 180 millimeters of water. So with the manometer connected, you press on the jugular vein, on the side where it is affected, and there should be, in the normal condition, there should be increased in pressure, roughly to the tune of 50 to 100 millimeters of water. But since there is a blockage of these by the thrombus, this pressure is not communicated, and so there is no increase to that extent. It may rise by 10 to 20 millimeters of water. So that suggests there is a obstruction. There is another test which is called Kraubeck test, wherein the internal jugular vein on the normal side is blocked, and so because the other side there is a blockage of the internal jugular vein, the sigmoid sinus. There is engorgement of retinal veins, and the papilledema seen in fundoscopy, okay, on the opposite side. These are the signs with which you can come to a clinical suspicion, and of course you have these various investigating procedures. You have also the blood culture which shows the bacteria, and once we establish that there is a lateral sinus thrombosis, the treatment is usually antibiotics and anticoagulants, and the lateral sinus surgical procedures are the lateral sinus decompression, ligation of the internal jugular vein to see that the infected material, or in the form of thromboembolic phenomena, doesn't go into the heart and into the lungs via the jugular vein, the innominate and superior vena cava. And along with that, the clot is removed, and in addition to that, you should also do a mastoidectomy so that the root cause of this infection is eliminated. Then we come to another complication. So we have seen the extradural, these are the extradural complications. Then we go a little deeper inside and you have the meninges, and the infection into these meninges maybe via the bony destruction they can travel, and they can from the dura mater they can enter inside and produce the meningeal inflammation. Or the bone may be intact, the infection may spread via the venous channels and the like the thromboembolic phenomena, and directly reach the meninges. Now in this, usually the children are the ones who are prone for this, and the clinical features that are described here are the high-grade persistent fever with rigors, severe headache and neck stiffness, the irritability, child is drowsy, and there is the confusion, and these are the various stages in which the infection presents itself. And there is neck rigidity, and which is measured by two tests. One is the Kernig sign, wherein you allow the child to flex at the hip joint and try to extend the knee, raising the leg, extend the knee, and they will have excruciating pain along the spine. And the second test is the Brudzinski's neck sign, where you flex the neck and try to fold the knee joint, and so which is once again painful. The management requires the lumbar puncture, where the cell count is high, the protein content turbid, and the sugar is low. And it also, lumbar puncture also yields that there is a increase in the pressure, and the treatment most of the time is by the antibiotics, gram positive and gram negative, to tackle the infection. And once the child or the patient stabilizes, you should do a radical mastoidectomy or whatever is the surgical procedure, in order to see that the primary focus of infection is totally eradicated. Then we go into another complication of the intracranial complication, wherein most of the time this kind of an infection spreads through the vascular channels. It may also spread from the destruction of the bone, dura mater, and then the other layers of the brain, and then it can reach the brain tissue proper. So basically, these are classified into four classes or stages, wherein initially there is a diffuse encephalitis, a diffuse spread of infection. Then it usually takes about 10 days. The patient usually presents with fever, malaise, and the fatigue. Then you have the body trying to localize this infection into a small abscess, during which time the localization, the symptoms totally disappear, and it becomes quiet. And then after a certain latent period, 1 to 14 days, there is enlargement of this purulent material, the pus, which forms a capsule and then enlarges and once again gives rise to the increase in the intracranial pressure, which in turn manifests as the headache, fever, malaise, and the papilledema. And then the next stage will be the rupture of this abscess, either into the ventricles or into the subarachnoid space or into the meninges, leading to a fatal outcome to the patient. Now, as I've already explained earlier, that the infection from the middle ear cavity or the antrum comes to the into the intracranium, either medial to the arcuate eminence, the temporal lobe is the one which is affected, and so you have this temporal lobe abscess, and if the infection spreads into the posteriorly via the Trotman's triangle, the infection reaches the cerebellum, and there are certain signs and symptoms which they manifest. In the temporal lobe, the nominal aphasia, the homonymous hemianopia, epileptic seizures, pupillary dilatation, hallucinations, and hemiplegia. These are the manifestations of a brain abscess, temporal lobe abscess. Then you have the cerebellum. Usually there is a nystagmus, weakness, and hypotonia, and ataxia, inability to walk properly. The intention tremor and fast pointing test, dysdiadochokinesia, which is characteristic of the cerebellar involvement. So once we suspect that there is a problem like this, the management is by the investigative procedures, the CT and the MRI. And we know the brain abscess or the cerebellar, either in the temporal lobe or it may be in the cerebellum. And the antibiotics to start with, but if the abscess is present, which is continuously threatening, then the surgical procedure is the burr holes that are made in order to reach that area and evacuate the pus. And if the procedure required, sometimes maybe the encapsulated, there is a capsule, so you remove the entire abscess cavity with the capsule. Okay? Then of course you have to attend to at a later date, once the patient recovers, at a later date you should try to reach, see the root cause of this infection spreading from the middle ear cavity or the mastoid. Then you have another condition which is called the subdural abscess, which is the space between the dura and the arachnoid matter. This mode of infection into this area may be with a bony destruction or mostly the embolic phenomena through the veins. And the clinical manifestations are usually severe headache, drowsiness, the convulsions, and the paralysis. And the investigations that are done for these patients are the lumbar puncture, where there is a increased pressure, and HRCT of the temporal bones. And once we identify there is an abscess deep to the subdural area, the treatment is by the craniotomy and draining of the evacuation of the pus. That is as far as the subdural abscess is concerned. This is a diagram which shows the dural layer which encloses the sagittal sinus, superior sagittal sinus, inferior sagittal sinus, the falx cerebri, tentorium cerebelli, and the various venous channels, sinuses of the intracranial. Now, we know that the CSF is produced by the choroid plexus, and from the choroid plexus it comes into the subarachnoid space and into the various cisterns of the brain and circulates, and ultimately it is absorbed by the arachnoid villi, which are present in the sagittal, superior sagittal sinus. So this is the circulation, how the CSF is produced, and ultimately it is absorbed into the system. This is a regular feature that happens. But when there is an obstruction to the venous sinuses, as we have seen, there is thrombus formation in the sigmoid sinus, which propagates itself in the transverse sinus and into the superior and inferior sagittal sinuses, where there is where you have these arachnoid villi, which are the ones which where the CSF is absorbed. So there is absorption is interfered with, and so there is increased pressure of these the intracranial, which is otherwise called benign intracranial hypertension, or it is otherwise synonymous Simon's syndrome. Now actually there is no dilatation of these ventricles, of the cisterns, but there is increased pressure. This increased pressure causes severe headache, the vomiting, blood vision, and papilledema and optic atrophy. So we should not allow this infection, increased pressure to continue for a long time. There are various, and of course along with that you have the abducens palsy and the diplopia. And we should not allow the pressure to build up continuously. So you can do repeated lumbar punctures. The lumbar puncture here actually shows that there is a increased pressure, more than 300 millimeters of water. Normal, I said, is 70 to 180 millimeters of water. And the biochemical examination is normal. CT scan brain normal ventricles. And the treatment result is either because of the pressure, it can be reduced by giving some steroids. The main purpose is to prevent the optic atrophy. But if the repeated drainage lumbar punctures are not helping, you can do a ventriculoperitoneal shunt, wherein there is a shunt from the ventricles, from the cisterns into via a tube either into the thoracic cavity or abdomen. And CSF autouria sometimes is another complication, wherein the infection from the middle ear cavity spreads by the destruction of the bone, destroys the dura mater, and so there is a communication between the CSF and which flows into the external middle cranial, from the middle cranial fossa into the middle ear. From there it may come out if there is a perforation from the ear, which is called CSF autouria, or if there is an intact tympanic membrane. Sometimes there may be iatrogenic CSF autouria, wherein the infection, the autouria, the CSF is drained via the eustachian tube into the nasopharynx. So this can be easily identified, and the treatment is once again identifying this defect wherever is the dura mater is there is a tear in the dura mater, is repaired by temporalis fascia and facial graft is placed and closed. And sometimes the sinodural angle tear is very difficult, which may require a repair by the neurosurgeon by the intracranial route. That is as far as the CSF rhinorrhea is concerned. Then there is another condition, CSF autouria is concerned. And the brain fungus. The brain fungus, similarly, when the infection erodes from the tegmen tympani segment antri, and there is a part of the brain tissue which is projecting through that weakness and presenting into the middle ear cavity, which is a rare condition wherein there is a necrosis, partial necrosis of the brain tissue. So in such conditions you remove the necrotic tissue, and the healthy tissue of the brain is pushed back into the intracranium, and the defect is covered, whatever is the prolapse, the defect is covered by the grafts, the temporalis fascia. And thank you for the patient hearing, and we'll come back to you on Wednesday next.
Stop.